Okay, let's get started here with Understanding Pain Part 2. If you have not seen Understanding Pain Part 1, you may want to watch that lecture first. We are doing a little bit of review with this, but that lecture, that Understanding Pain Part 1, really provides the foundation for Understanding Pain Part 2. All right. Who am I? So if, as you may remember last time, I'm an anesthesiologist. I was trained in Chicago. I was also fellowship trained in pain medicine. And what that really means is all doctors go to medical school. Then all doctors do a residency where you learn your primary specialty. Mine was anesthesia. And then some of us then do additional training where we learn subspecialties or some, really learn the top information. And I did that in pain medicine. Now, after I did all my training, I went into the Navy because they paid for medical school, and I was stationed in San Diego. Great experience, great people I worked with, and it was a little bit unique because not a lot of people coming out in pain, particularly if you're coming out of fellowship. Most people either start their own practices or they're in little small groups with one or two other people. I came out and I was practicing with 6 other fellowship-trained docs, so all physicians that were trained in pain, great institutions, were supposed to, knew all the stuff. I brought my knowledge in, they had their knowledge, we shared back and forth. And we had a very diverse patient population. We had patients, 18 to, generally 45-ish because that's the nature of the military. But the types of pain that we were seeing was all over the map. Back pain we saw. We also had, we're in the middle of the war on terror, so we had people who had lost limbs, that had horrible trauma, had been in these IED explosions and things. And it was, a great mission, a very wonderful mission with what we were doing. Now, I did have some frustrations with that, though, and that was because the group practice model and the nature of the military when you're getting deployed and things is we would see a patient, or say I would see a patient in a clinic, and then I would either recommend something being done or not. Remember, in pain medicine today, so much of the focus is on injections and things, which we'll touch on later, but deciding would it be an injection or would one of these kind of interventions be appropriate or not. Someone else then may do that injection, or they may do something else, and then the patient may follow up with a third physician to see what the results are. Now, for myself at the time, it was very frustrating because I thought, maybe a little arrogantly, that if I saw the patient, I was then doing the procedure on them, and then I could follow them up by myself, through that whole process, that my outcomes would be significantly different. And outcomes for me, I guess I should qualify that. What are outcomes for your health? All right. My view on health is you go to a doctor because you want to get well. Most of us do. Getting well means the doctor provides you the education, the tools. In some situations, if something needs to be done, procedure, surgery, or something like that, that needs to be done to kind of get you over the hump, we do those in order that you can go on and live your life. It really shouldn't be a relationship where you have to see us all the time, every month, every 2 months, every 3 months, every 6 months even. We come in, we help you, we give you what you need, or provide you what you need, or help you through what you need so that you can get on and live your life and become well. All right? And that's my view of what success is. All right. So I wasn't seeing that as much in the military and I thought it was good to do this practice model. So when I left, I went into basically become a solar specialist. And I joined a multi-specialty group. So I joined a group of physicians, but I was the only pain physician in that group. So I was seeing the patients, I was treating the patients, and I was following up on the patients. And what I discovered was that my outcomes were not significantly different. People were saying, thank you so much, or not, but they weren't what I would call getting better, meaning they were not coming back. And if you look at a business model, I guess that's not the greatest business model of all. It is not to want people to come to see you all the time, because in medicine we're paid and incentivized to do things on you, and it obviously makes more sense from a money standpoint that you come and see us frequently. But from a standpoint of really wanting people to get better, I didn't want to see that, and I did, and they kept coming back, or it didn't seem to help them long term. They may say, maybe their back pain improved with something that we did, but overall, when you started looking at their chart, they were having pains in other places, and they were still seeing the physicians frequently. It was very frustrating to me. So then I started going back and going, well, why is this? I'm fellowship trained. I came from some great institutions with my residency and my fellowship, and had this great experience in the military. I was helping to teach residents and fellows in pain. I should know this. Why are my outcomes not what I would call, why were not we getting people well? And so really in 2011, certainly in 2012, I really started going back through the literature, started looking beyond the field of interventional pain and looking at the other aspects of pain, really went back through the definitions of pain. and realize relatively quickly that the way that we're treating chronic pain in this country is wrong. And our outcomes show that, because we are spending more money, we're doing more drugs, we're doing more procedures, and our outcomes are not what I would call good. So pain, again, just to refresh us here, pain is an unpleasant sensory and emotional experience, which we talked about last time. So it has to have all three of those things. There's the sensory component, there is this emotional processing that tells us what that sensation means, and then it generates a reaction or the experience or behavior from it. Now, what pain isn't, and this is really critical to understand, because this is where most of the misinformation from the media comes from. This is where most of the misinformation comes when people are getting treated for the pain experience, is it is not nociception. And nociception, remember, as we talked about last time, is just a stimulus and a signal. If someone poking you with a needle in your hand, or you touched a thorn, or someone's pushing something on you, or a drop of hot oil spilled on your skin, and that generates the signal in those little nerves that goes up your spinal cord to the brain. That is it. All right, it's the little spark coming from your body going up to where the brain is. And we call that objective, meaning we can measure that spark. We have the technology now. We can measure how intense that signal is. And even if your brain is asleep, meaning we put you to sleep under anesthesia, you will still be generating this nociceptive information from your body, these little sparks of information coming from your body. Go to sleep under anesthesia, surgeon cuts you, there's still these little sparks going up your spinal cord, but there's no brain to process it. Now, pain is a process. It is not only the signal, or that stimulus plus the signal, but is the meaning that signal has. And because of this, it is produced entirely in the brain. So while you may have a sensation in your toe, if you stubbed your toe, that actual pain sensation is in your brain. And it is purely subjective. And what that means is pain is unique to the individual. We cannot measure pain. We cannot, there doesn't seem to be a correlation between what the nociceptive signal is. And remember, I said nociception, we can measure it. And so we can measure these little nerves firing. But how intense or how high they fire doesn't relate very well with what someone's pain experience is. And the other thing to remember is that because of this, because pain is produced in the brain and requires a brain to process all that information and generate this pain experience, if we turn off your brain, you no longer have pain. Okay. So then we didn't touch about last time is this idea between pain and time. And this comes down to two different types of pain. There's acute pain, we call that now pain. And we have chronic pain, which is really pain that's always there. All right, and in acute pain, by medical definition, is really anything less than 3 months. And chronic pain is anything over 3 months. And we use this distinction because the idea being 3 months should provide enough time if there was tissue damage for the tissue to heal. So if you sprain your ankle, it should get better within 3 months. Sometimes it's longer, sometimes it's less, but it's a time frame that we use. Now, acute pain seems to have a role in a lot of ways, and it's, we call it adaptive. There's generally the sources defined, and something has occurred. Say you break your leg, or you get a cut or wound in your body, and the pain in that situation is telling you, pay attention to me. I need to recover, I need to bandage this, I need to take it easy for a while, allow this to heal. And acute pains overall generally respond to things like cutting, poking, and drugging. It may not be the best thing all the time, but they will respond to it differently, because if you have a broken leg that needs to have, say, a rod placed so that, that there's something that fixes that leg together until the bone can heal, that's where surgery would come in. Drugs for, we were talking about maybe an infectious process. You have a bacterial infection and you got some big oozy sore that's all inflamed and hurting. Then an antibiotic at that time may help to get rid of the bacteria and decrease that infectious process, in which case it should respond to that. Now, chronic pain is very different. It's what we call maladaptive, or really bad in some ways. It's more nebulous. It's harder to define a specific location for it, although not always. And it has much more of the central role, more of this brain-based phenomenon when it comes to it. And a good example of a chronic type of pain is fibromyalgia, where you have widespread pain above and below the belt line, both sides of the body. May get better and worse in some days. One area may hurt worse than the others, but there's no single treatment that really fixes this. Okay. I mean, this is not a broken leg that we can fix with putting a rod in and stabilizing it. They certainly don't respond to our 3 medical therapies of surgery, injections of drugs, or cut, poke, and drug. Now, there is overlap with these, as I said. Remember, pain overall is a sensory and emotional experience. And if you kind of look at this construct here, this diagram, it kind of helps to see where that overlap is, because acute pain being more of this probably sensory role, more of a nociception input, meaning there's signal coming from the periphery that seems to be driving most of the pain, but it still requires the brain, that overlap there, that brain to tell us what that sensation means and how we should respond to it. In chronic pain, the areas out in the body are less important. Sure, are they sending information, but it's much more how that brain is processing that information. In some situations, information coming from the body, these signals from the body may be perfectly normal, but the brain starts processing them as pain. Okay, and we sort of view this role here, the treatments then are quite different in a lot of ways, because for chronic pain, if we're focusing all our attention peripherally, out on those nociceptive signals, we're not addressing that main component, that processor there. And so one of the things I used to kind of describe this on the last lecture, when I was talking about the three dimensions of pain, and we said, well, there's the sensory discriminative, the affective motivational, and the cognitive evaluation branch for the three dimensions of pain. And what those related to was, the sensory discriminative branch bring that more of that nociceptive signal, like the microphone here, and I can talk into the microphone louder, 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 and change the signal to it, or talk less and less and less and make it softer. Then there's the affective motivational branch, which is that mixing board that, the microphone goes into that mixing board, and there's all those dials and things on like that. And we can, if I talk less, or I'm talking the same on that microphone, but I start playing with the knobs on that mixing board, and I turn up the volume higher and higher in some ways, we can change how the pain is described, or at least outputted. And chronic pain is more of a mixing board phenomenon, meaning it is much more involved on that processing side. And another way that I think is important is, if you look at how chronic pain is, one of the reasons that our injections don't seem to work really well for it is we haven't fixed that processing role. So even if we can go in and we can completely stop the nociceptive signal coming from your toe or your back or whatever, you will still have information. These little nociceptors are all the way through our body, so you will have information from your head, from your shoulders, your fingers and things. And if your brain is processing the information differently, even if we took away that one painful area, you will still have all these other areas of the body sending signals, and the brain can take those normal signals and amplify them and express them as a pain experience. Hopefully that makes a little bit of sense. I know sometimes I talk a little bit too much about this, so I'm going to keep going on. And remembering that our pain experiences are influenced by past experience and trauma, the nature of the injury, what previous injuries that we had that were similar or maybe not to the injury that we're having now, that provides context to it, makes us either, maybe you had an injury and when it first occurred you didn't think it was a big deal, and it ended up to be a huge big deal, much more painful than you remember. Then you have something that happens again similarly, and you feel a similar sensation, and then you think, oh my God, this is going to be as bad as it was last time. That experience is going to change how you express that pain. Then there's uncertainty and fear, which we talked about last time, I believe. And it's when you are uncertain or you're fearful of what the pain means, that can increase the sensation of pain, increase the experience of pain. And then there are beliefs about the pain itself, whether they're what we would call good beliefs or bad beliefs. Good beliefs being, I use an example of back pain. So if you are say you have been active but you stopped your workout regimen for a while, and then you went back to working out or exercising, and your muscles are very sore, your back muscles are very sore. Now that is unpleasant. I've been sore more than once in my life where it was bad, barely even could move or stretch out an arm or a leg. But because I knew what it was from, it was because I worked out too hard, and I knew that it probably wasn't going to stick around forever. There was no uncertainty there. There was significantly less uncertainty. And so while the pain was unpleasant, it wasn't what I would call a bad belief, because I knew it was going to get better. I knew it was in the context where I understood it. A bad belief would be when we view the pain as something it is not. Most acute pains are going to get better with time. When we look at back pain, most back pain will improve with time. And bad beliefs are often propagated by us as physicians. So I'm going to talk about back pain specifically in its own lecture later on. But a quick example here is if you have back pain and you've had it just for a couple days and someone gets an x-ray and an MRI, the danger with that is then because doctors always want to help people, and we want to always know because we're supposed to be the smart person. The danger is then we say, you know what, you probably got your back pain because you've got disc degeneration or you've got bulging disc here. When we cannot say that, because the amount of those findings that we see on imaging, whether bulging discs or degenerative joints or whatever, vast majority of them, if you scan people who had no back pain, they're going to have them the same or worse as you. And there is no really good correlation between those imaging and pain, and we're going to touch on that more in back pain. But what we've now implanted in you is a belief that your back pain is due to a bulging disc, that somehow there's a structure that is damaged in there that you can't improve on your own, that somehow may need to be fixed, or is there in such a way that you are going to be, you're going to have a bad back forever because you always are going to have that degenerative disc. And that, frankly, is completely wrong. And we've now created that belief in you, and we've now influenced in a maladaptive, in a bad way, how you're going to express pain and how you're going to live with your pain. Now, I call this the 4 horsemen of pain. These are 4 emotional states that really are harmful or worsen the chronic pain experience. The first one is depression. The second one is anger. The third is anxiety. And the fourth is fear. Now, anxiety and fear do have some overlap and interplay there, but they're so important that they each deserve their own little category here. And besides, the 4 horsemen of pain sounds much better than the 3 horsemen of pain. Now, when we look at depression, particularly with chronic pain being over 3 months in duration or longer, 40 to 50% or greater of patients with chronic pain have some degree of depression. Now, there's a lot of chicken and egg arguments here. Do people with chronic pain develop depression, or is it depression predisposes chronic pain? And while there's some studies supporting each, we do know that depression definitely predisposes people to chronic pain. Now, there was an excellent study that came out in around 2005 looking at the development of low back pain as a prospective study, meaning we studied patients and then they watched them over time. And the number one risk factor, the number one thing that predicted the development of the chronic low back pain was the level of depression. And it was a stronger predictor for the development of chronic pain, better than any sort of clinical or anatomic risk factor, better than bulging discs or anything else, was this level of depression. And there's some reasons for this, which maybe I'll go another lecture on the physiology of depression and how it actually influences our body, but not for this lecture, sorry. Now, 40 to 50% of chronic pain patients, though, aren't depressed. Why is that? You would think chronic pain, unpleasant sensory emotional experience, you're experiencing it every day. How come everybody who has chronic pain isn't depressed? We're going to touch on the reasons for that towards the end of this talk. Now, anger and pain, it is widely observed, okay, particularly in chronic pain. It's been estimated 80 to 90% of patients with chronic pain that have been referred to these big name pain centers report feelings of anger. And interestingly, there's a strong predictor of increased pain. People who have a lot of anger have an increased pain experience. And specifically, it's when that anger seems to be inhibited. People that are feeling this aggravation, this irritation, but then they sort of clamp it down and try to repress it in some way. It seems to amplify this pain experience. Now, there's some really interesting studies on this. And one of them, they took healthy young adults, patients that did not have chronic pain, and they put them into an environment where the experiment was really designed to see this irritation model. And so they took 2 groups, and in one group they had a participant, it was supposed to be another study participant, but it was actually an actor, and the actor's only job was to irritate these people. And in one group of these healthy young adults, they were told just, wait in the waiting room or do your normal activities. In the second group were told, sit here quietly, don't talk to anybody and don't respond, basically play nice. And what they found was the patients, or these healthy people that were not told to repress these feelings, or originally said, just wait, but do whatever you want, when these actors went in and then irritated them, they could express their emotions and say, hey, you're annoying me, stop, please, stop bugging me. The other group that was told to basically sit quietly and not respond, when these actors went in and the only thing they were trying to do was irritate these people, that group, when they did experimental pain studies, meaning we put we put their arms in cold water, or we squeeze their arms with cuffs until they start that little nociceptive signal starts getting really high, and you start feeling it and you start expressing this pain. They had decreased pain tolerance, meaning the level of nociceptive input that we did, the amount of pressure that we put on them, the amount of cold that they were under was less. for the degree of pain that they said, and the pain intensities were higher. So they took this information, then they applied it to chronic back pain patients. And this was fascinating because what they found for this study, if I remember this particular study correctly, they had the chronic back pain patients doing a very difficult maze kind of thing on a computer screen, and then there was supposed to be another study participant who was supposed to be helping them do this maze activity on another computer, but they were talking back and forth. The other person obviously was not a study participant, was an actor, and all they were doing was basically yelling at the chronic back pain patient doing this exercise. You're too slow. How come you did that? You know, you're dumb. Why are you not faster? You should. Oh, that was a dumb move. And again, the group of chronic back pain patients, some of them could say, you know, shut up, dude, quit bugging me. The other group was just sitting there quietly because they weren't supposed to respond to this other participant. And those group that had to repress this irritation or repress this anger had increased pain behaviors, moving around more, squirming in the chair, uncomfortable. Interestingly, they measured their back because they were having increase in their back pain, their chronic back pain during this activity. And so they took these little needles and they look at the muscle activity, saw the muscles were contracting or not. We called that by something called EMG. And those low back muscles were actually spazzing. They were firing. And it wasn't like these people were all tensed up, like they were so upset that they tensed their entire body up because they were so irritated. It was just the areas in their low back where their chronic pain was. So by changing this emotional state, by causing them to inhibit this anger, we were increasing their chronic pain and increasing muscle activity just by changing their state. Right. Incidentally, they also had decreased pain tolerance and increased pain intensity too to experimental pain. And now, who are these patients angry at, though? Who is most commonly, particularly with chronic pain, who are they angry at? And there's a lot of different reasons. They can be mad at docs for failing them. They can be mad at lawyers for lawsuits or compensation or whatever the case may be. They can be mad at family or spouses or friends or whatever. But the most common person that they're angry at is themselves. Okay, and when I first read this, it took me a while to kind of think about it, but it kind of makes sense because oftentimes we will blame ourselves for what occurred. And so much of it in our life happens, and there's nothing that we can do about it, but we go, well, I'm so stupid. Why did I not do this? Why did I try to lift that block? Why did I try to, rush across that crosswalk? Or I should have done that. And there's this degree of self-anger where you're just so upset at the past decision that you had, and you keep living that over and over again and maintain this anger intensity here. Now, what about anxiety and fear? I love this quote. But the enemy is fear. We think it is pain, but it is fear. And that was said by Gandhi. Now, actually, he said, the enemy is fear. We think it is hate, but it is fear. But pain sits much better, and it really makes sense in this way, because when you start looking at the information when it comes to anxiety and fear and pain, it is quite concerning. So when it comes to anxiety and fear, over 40% or greater of patients with chronic pain have some degree of anxiety and fear associated with it. What we do know is that anxiety and fear primes pain sensation. And what that really means is it's setting up the stage. It's making your brain really saying, okay, any sensation that comes in, we're getting ready to process it as pain. Okay, because we're in the state where we're more likely we're seeing things as a threat, and this is going to be painful. And so when we talk about that mixing board, this takes that volume control. Remember I said there's two ways that you can really control the volume in that mixing board. Is you can either yell into the speaker, or you can turn up the volume on the mixing board. And what this anxiety does is takes the volume control and sets it up to 10. Right, so even small little, voices in the microphone are going to sound very loud and uncomfortable because that volume control on the mixing board is set so high. And one of the reasons or one of the propagators of this anxiety and fear is uncertainty. When you're not sure what the pain means, or we can't describe it, or we can't find a good explanation for it. Now, related to anxiety and fear is catastrophizing. And what catastrophizing is an exaggerated focus towards the actual or anticipated pain experience. And a bad example of this is someone, say, stubs their toe. Most of the time, you stub your toe, it hurts. That's it. You don't really think about it. If you're really catastrophizing, you would stub your toe and you'd be like, man, my toe hurts. And then maybe because you're really now thinking about your toe, that may get a little more intense. You're like, man, this is getting worse. And then you start thinking, God, this hurts so bad. I must have broken my toe. And then you think, oh my God, I broke my toe. I'm probably gonna have to go see the doctor, and that's gonna be expensive. And then you start worrying about the cost, but you start worrying about your toe, and then you go, oh, it's probably a horrible break. I'm gonna need to have surgery, and the surgeon's gonna go in there, and something's gonna go wrong, and then maybe I'm gonna get an infection after the surgery. And I'm gonna get some sort of horrible flesh-eating bacteria, and I'm gonna lose my leg. Okay, all from this initial action of stubbing their toe. And while this is obviously an exaggeration, this occurs where people will take initial injury and they basically visualize the worst case scenario, no matter how likely or unlikely that result is going to be. They visualize that and then they pull it in their current experience and start ruminating and focusing on it and basically living it now. And what catastrophizing does is it increases pain behavior, and increases dysfunction due to pain. Outcomes are worse. When people start catastrophizing, one of the first things that we need to do is get them to kind of pull it back together, reframe the event, and to realistically assess what the situation is. Because once you sort of ramp this up, it becomes very difficult to control. Now, kinesiophobia is more of a focused catastrophizing, and what this is, the root is being kinesio, meaning movement, and phobia being fear, excessive fear of movement and injury and re-injury. What this is, and a good one to think about is back pain, is people become scared to move because they're scared they're going to have back pain again, or that because of their movement they're actually going to make their back pain worse. Now, if you know anything about back pain, actually we do need to move. That's one of the best things to do for back pain, but get this fear. You don't want to move because you're convinced if you move, you're going to hurt yourself again. And what this does is it actually predicts functional limitations. It predicts what people can and can't do once they've been injured better than anything else. This belief here, this fear of movement, not MRIs, nothing else. Fear of movement. It predicts the performance of people with activities, and it predicts disability. So patients that have this excessive fear of movement due to, and back pain, that predicts disability due to back pain better than just about everything else. We're talking, MRIs again, work demands, all that stuff. Is this fear belief. And if you look at back pain, and as I said, we're going to do a lecture on back pain later on, the biggest risk factors for developing and maintaining chronic low back pain are not MRIs or MRI findings, not bulging discs or anything like that. They really come down to a lot of bad fear beliefs. Now, what do fear and anticipation of pain do together? Well, they provide strong negative reinforcement. And what does that mean? It means that it keeps, initially, when you hurt yourself, you don't want to move, right? You say you hurt your back and you're moving around and it hurts your back. You just want to lay there still or lay on a hard surface so that you're not moving. And when you're not moving, the pain seems to improve. So there is a negative reinforcement. You take away that painful stimulant, you want to maintain the behavior that took it away. Now the problem with this though is it causes persistent avoidance, meaning people will stop doing those activities and they will become fearful and stay away from them. And avoidance behaviors have a host of different things associated with them which are not good, which I'm going to touch on a little bit here. And this causes, again, the short-term cessation, causes that pain to get better, at least it appears to, temporarily, until you want to start moving again. Because you can decondition very rapidly, particularly if you're over the age of 35. You start losing muscle mass acutely, then you start getting your ligaments started to tighten up again, so that when you move again, you have more areas in the back that are now deconditioned, weaker, that will send some nociceptive information to the brain. The brain then takes that information and says, ow, this is pain, in which case you now want to not move again, because in the past, when you don't move, you don't seem to hurt as much. It becomes this vicious cycle so that you are not doing what you need to do. Now, the other part about this, which is going to become important, is that avoidance, that persistent avoidance, because you are no longer challenging yourself. You're no longer putting yourself in situations where you can, instead of looking at this is going to cause me pain, looking at an aspect of, this was going to be a challenging move, but I got through it okay. And that's going to be, remember that. That avoidance propagates this idea, or it doesn't allow us to have these chances to demonstrate success. And that's going to be important in just a little bit here. So the overall effects of the 4 horsemen with pain is that when you're depressed, you feel helpless and hopeless. Depression is like this black pit where you can't get out of it. If you're really in the depths of it, you don't have any energy, you feel helpless, you don't think anything's going to work, you feel hopeless that there's anything that you can do for your pain. Now, if you're angry, you become frustrated, you become unmotivated because you're things have failed in the past, and why should you try anything new? And then the anxious, and you're fearful of worsening the pain, and it's going to cause it to come back again, and you become living in this fear of developing the pain, or fear of movement, which keeps you from improving. Now, what about those non-depressed chronic pain patients, though? At least 40 to 50% of them, we said, don't have depression. What was the secrets there? And really the key thing that they found for those non-depressed pain patients was that they believed they could still function and that they had some control over their pain and lives. And there's 3 words I want you to look at: believed, could, and control. And this is going to lead us into the 4 noble truths when it comes to chronic pain. The first one is perceived control. The second one is self-efficacy, optimism, and hope. And lastly, benefit finding. We're going to go through all of these. Now, perceived control versus learned helplessness. Perceived control really is this belief that you can. It's the belief you can exert influence over your situation. Versus learned helplessness, which is this belief where you've learned that you have no control over your situation. And important to remember, those are beliefs. And it's really a perception, okay, rather than reality, because there's a lot of things that we don't have any control over. But a person who has a strong degree of perceived control has something that's called an internal locus, meaning that they know or they feel that their actions actually influence the environment around them. And it becomes less of a question of what others are going to do for them, but how can they get the right information? How can others help them to help themselves? Well, someone who's got learned helplessness is belief you have no control over your situation. That's what we call an external locus of control, where you don't feel that you can control your situation, but it's everybody around you that controls what happens to you. So now it becomes someone else needs to do this for you, or that doctor is going to cure you, or someone else is going to be your savior. This is a very dangerous situation to be in, because you're not allowing yourself the opportunity to help yourself. It becomes others are the only people around you can help you, and you have no input into your own situation. Now, what we find with perceived control, people have high degrees of perceived control. They don't get disabled as easily. There's a decreased rate of disability associated with it. While people who have this external locus of control, this learned helplessness, very strong contributor to disability. They seem to do much worse. Now, self-efficacy is a belief you can successfully perform a certain task or produce a desired outcome, meaning you can do something. You feel like you can and know you can do something. This increases function. People who have this high degree of internal control function better. They actually have better pain tolerance. Now, here's the critical part, though, is that past success is important. Self-efficacy, sorry, I'm stumbling over that word, is what we call a mastery belief. That you have had the opportunity to face challenges and overcome them, or if you didn't overcome them, learn successfully from them so that you could overcome them later on. All right. So having these little small successes in your past are important to be have a very self-efficacious viewpoint for yourself. Now, remember what we were talking about with fear and anxiety and avoidant behaviors, where they start taking you away. They start encouraging to avoid those situations where you may or may not have an outcome where you have worsening of pain, or worsening soreness that becomes back pain, or where there's a chance of failure. You stop getting into those challenging situations. Well, you stop doing that. You stop putting in those situations where where one way you can say it is, well, I'm avoiding them because I don't want to hurt. But the other way you can frame it is, because I'm avoiding them, I cannot ever get better, because I will not have any successes to learn from. And this ruins your mastery belief. It really ruins your self-efficacy. All right, so fear and anxiety propagates that avoidant behavior, really takes away your mastery, while self-efficacy is really this belief that you can get better. It is important that you have those opportunities to improve over time. And whether it's even small steps, whether you haven't walked and now you're walking a block or half a block, but putting yourself in a situation where you can take these small little steps to demonstrate to yourself that you can do something. Critically important for self-efficacy. Now, optimism and hope are somewhat related, but I'm going to kind of distinguish them. That one, for optimism, it's more of a general expectation, a general belief that you're going to experience good things versus bad outcomes in life, that you perpetually see the glass is half full. Okay, now hope is more of the perception of an end-focused goal. So you can plan and pursue progress towards a goal. So you hope that this particular outcome is going to occur, rather than just a general belief that good things are going to occur. It's more of a focused expectation. Now, you take these together, though, and you look at both of them, You have increased health. They seem to people who have high degrees of optimism, that are highly hopeful people, hopeful that they're going to improve, or whatever the case may be. They adapt better. They recover from things like illnesses and surgeries quicker than other people. And when you look at pain, it decreases the pain experience, because there's a degree of knowledge of this won't last forever, or that there's good things coming from this, or in the end this will all be worthwhile. And this relates into benefit finding here. And what benefit finding is the ability to identify positive aspects of adverse life circumstances. And that's a bunch of long speech to basically say this is the ability to find the silver lining. And why that is important is because if you can find a silver lining, if you describe meaning to these negative events, it means you're using them as a learning experience. Okay, and people that have this degree to find benefit in bad situations, they have decreased levels of stress, so your stress is less. They seem to adjust to their new experiences better. Pain overall is decreased in them. Okay, now why is this? Well, all of these four noble truths are what we call solution focus. You're not focusing on just the pain. You're focusing on what you can do to improve. What's the solution? How do you get well? How do you live a better life? And they are very flexible and adaptable. They're not rigid mindsets where you're pounding against the same thing over and over again. They allow you to learn, and they allow you to be flexible. So if you perform one exercise or one side of activity, or you've tried this particular therapy and you've given it a good shot and it doesn't seem to be working, it allows you to adapt and say, you know what, I don't think this is working, but I can pursue this other thing, not the same thing, and we'll see how that goes. Because knowing what works, or I should say knowing what doesn't work for you, is as important as knowing what works. Because if you know it doesn't work and you've done a good shot at it, as I said, you put a lot of effort into it and it doesn't seem to be working well, then you know what, I probably shouldn't do that again. I should look for other avenues. This becomes important because with chronic pain, I see people having the same things done over and over and over again. They've gone to one doctor and they get a bunch of injections. They go to the next doctor who repeats all the same injections. They go to a third doctor who wants to do all the same injections again, and they're expecting different results. Now, I think it was Albert Einstein that basically said, if you're doing the same behavior over and over and over again and you're expecting a different result from it, that's the definition of insanity in a lot of ways. And I'm not saying people that have chronic pain are insane. What I'm saying is that you need to be flexible and adaptable, that you have to look and say what is working and what isn't working, and focus on what is working, and remember what didn't work so that you don't keep repeating it over and over again. The other thing that these do is they allow you to reframe the situation. The ability to reframe and provide context to an injury is very important, and being able to if it's a minor trauma, to recognize that that it could have been worse in a lot of ways, being able to frame it and saying, oh well, this is bad, but at least it wasn't X, Y, or Z. And the other part about it is it leads to an acceptance, and I call this the now what stage. Okay, because when something happens, we all, when something bad happens, we all have a tendency to live there for a while, and we have to. That's part of the process of dealing with it. Really, being in the moment, recognizing it, living in that traumatic experience. But at some point, you have to say, now what? And say, I'm not going to be who I was yesterday. I'm not going to be who I was 2 years ago. I'm not going to be who I was 20 years ago. I am who I am now. What do I do next to live my life in the best way possible, so that I have, I enjoy my life, that I can enjoy my family and friends, that I can have a meaningful existence again. So acceptance really allows you to do this. Is what? And a big example is this. I saw these guys that when I was in the military that had lost limbs, sometimes multiple limbs, in blast injuries. And the best ones that could say, what, this occurred. I would not choose this, but it did. But I'm going to take this situation, and I'm going to take the information now, and I'm going to be either teach other people, or I'm going to, talk about war, I'm going to show other disabled people what they can do. I'm going to accept where I am, and I'm going to take what I am now and try to be the best I can be. And critically important, acceptance is huge for a lot of this. Now, what does this all mean overall, though? Number one, and I'm going to hammer this home until I'm blue in the face here, pain is not nociception, right? Pain is not bulging discs. Pain is not degenerative disc. Pain is not little nerve fibers in the periphery that must be causing the pain. No, that is just the nociceptive signal. All right. We know people who have degenerative discs and bulging discs and degenerate spines and weird nerves in the periphery that do not have pain. Right? But we focus so much on that nociceptive signal, and pain is not nociception. It's a sensory and emotional experience. The other thing to remember is chronic pain is not acute pain. And when we're looking at that, meaning acute pain generally has more of an adaptive role, it might have more of a sensory component to it. It's trying to tell us something, whether we need to clean the wound or get stitches or get a splint or something. But chronic pain, duration of pain, we are starting to process information differently. That is much more of a centralized phenomena. Remember, the mixing board starts being changed. The volume control gets set on high. The gain on the microphone starts getting set on high. It starts taking information that would normally be normal information, and there's all sorts of nerves that we have firing in our body all the time. When you take a step, there's billions, if not trillions, of nerves firing that are giving you what we call proprioceptive information, where the location of each piece of your body is in relation to time. And in chronic pain, when you start processing this information differently, you may take what are normal information, even these information of just where your body is, this proprioceptive information, and now process it differently and assign it a pain value to it. So much more of a central process when it comes to chronic pain, much more of the centralized process. And then we also have to remember that that pain experience then, from that brain, all pain being in the brain, is influenced by the perception of the event and how we perceive our pain, our beliefs of how the pain began, as well as our belief about pain now, and then the meanings that we're ascribing that pain. We change these things. We change the meaning. We can change the feeling. All right, a little bit longer than the last lecture. I apologize for that. We had a lot of information to cover. But if you have questions, if you have comments or confused, if you're not seeing this on straightshothealth.com, visit there. You can email me directly at drkevin@straightshothealth.com. And until next time, stay well, guys. Thanks.